Good evening, dear colleagues. We are happy to welcome you at our webinar, international webinar devoted to the revolution in the diagnosis of transthyretin cardiomyopathy. Distinguished colleagues, during the previous webinar, we tackled the issues of red flags, diagnosis, clinical diagnosis. We have been speaking on what challenges we face dealing with our patients, what obstacles they have to meet, and normally this is quite a long patient journey from the first symptoms up to diagnosis, from neurologist to cardiologist, or from gastroenterologist to neurologist, and then to cardiologist, etc., etc. So, and in order to have correct diagnosis of transthyretin cardiomyopathy, normally it takes about 3 years. So, terrible delay of the diagnosis. So today, we are together with our distinguished guest, Dr. Horхе Кардона, who is our distinguished guest today. So today we will discuss actually how we can make the diagnosis for our patients better and faster, patients with transthyretin cardiomyopathy. So in fact, this is the revolution in the world of the diagnosis of this specific pathology. So once again, I would like to say that until very recently, amyloidosis considered to be the capital punishment, and we fully understand the earlier we make the diagnosis for the patients of cardiomyopathy, transthyretin cardiomyopathy, the faster we can expect the prescription of the drug that can easily save and prolong the life of our patients, to slow down or to cease the progression of this disease. So now it's my greatest pleasure to give the floor to our guest, Professor Horхе Kardona, who is representing Department of Nuclear Medicine, Hospital Universitario Pуэрта-де-Йерро Mahadahonda. So it's very important what multidisciplinary colleagues may say to each other. So it's very important to radiological diagnosis here. Radiologists are actually supporting us, and we normally have many questions to them. And possibly our patients do not need such complicated and long diagnostic journey. Maybe our colleagues radiologists would give us a tip, a useful tip. Maybe immediately patients could be sent to scintigraphy as a first line, and already there we could see the changes, and we can suspect that patient has already some cardiomyopathy. So now, dear Horхе, the floor is yours. Please start.
Hi, first of all, thanks to the organizing committee for inviting me for this presentation. And I would like to begin the presentation with one question. And the question is that why the bone scan is becoming so popular now in cardiac amyloidosis? Well, I think that there are several answers to that question. The first of all is that the ATTR cardiac amyloidosis has been considered a rare disease, but this is something that we have seen that it is not really true. The prevalence of the disease is much higher than we thought. Also, it has been reported that a grade 2-3 cardiac uptake on bone scan, plus the absence of a detectable monoclonal protein, is almost 100% specific and 100% positive predictive value for cardiac ATTR diagnosis. Also, the bone scintigraphy allows an early identification of the ATTR cardiac amyloidosis in asymptomatic patients before clinical presentation. This is very important with the development of the new drugs that try to not cure but just slow the disease, and the earlier the disease is detected, much better for the patient. And I think another point, and I think that it is very important, is that the bone scan, it is a non-invasive test, so you can perform it without any kind of risk for the patients. So, talking about the prevalence of the myocardial uptake in the bone scan, several studies have been reported. One center studies that the percentage of the myocardial uptake in the bone scan for extracardiac pathologies goes from 0.23% to 0.78%. Here in Spain, there are other single-center retrospective studies that tells that it goes from the 1% to 2.8% of myocardial uptake in the bone scan. And I would like to show you one recent paper. It has been written by my former colleague, Dr. De Aro, but he retired, and now I'm trying to continue his job here at the hospital. And it is the EXINGO study. Okay, this is a retrospective national multi-center study evaluating the prevalence of incidental cardiac uptake in bone scintigraphy performed for non-cardiac reasons. Okay, they take almost 10,000 scans, bone scans, and they found 0.72% positive. Almost the 75% of these positive studies were score 2 or 3 of Perugini, and only 10 patients were diagnosed of cardiac amyloidosis. And this is because this was a retrospective study from 2019. Before the COVID, they reunite these scans from September to November, I think. From September to November, trying to avoid all any COVID interference. Okay. And at that moment, and not all the centers has a specialized department for these familiar cardiac diseases. So that's why the only 10 patients were followed up, and they found that they had this cardiac ATTR amyloidosis. They found that the prevalence increases with age. Almost all patients were older than 70 years old, and 4.8% of patients older than 85 years had this positivity. Also, they found that the prevalence increases too with the male sex. That maybe here there is a selection bias because of most of the bone scans were performed in patients with cancer, with prostate cancer. So there could be a bias there. And an important thing that they found is that the hospitals located in regions with endemic mutations show similar prevalence to the rest. In Spain, we have different communities like Mallorca and Huelva that had this BAL30 mutation, and it has been reported that some kind of mutations has less added are less added for the bone scan uptake. So I think that the cardiac amyloidosis and the ATTR cardiac amyloidosis is very like to an iceberg. Okay. So why the bone scan I'm going to show you the advantages of the scintigraphy, the bone scan. Well, it has a very high sensitivity and specificity. It is a non-invasive test, as I have told before. The availability and cost. Almost all nuclear medicine department has a gamma camera, and almost department has the SPECT-CT cameras. Also, it has the capacity for differential diagnosis with other types of cardiomyopathies that present with ventricular hypertrophy. The quantification values are related to survival and are prognostic factors too, and the visualization of the cardiac involvement before the clinical presentation. It is very important to diagnose the disease before the onset of the symptoms, just to start much earlier the treatment. Regarding the bone scan real tracers, the one that you are going to use, it depends on the country that you live on. Here in Europe, in Spain, we use the DPD, okay, but almost the three more used real tracers are the HMGP, the DPD, and the PYP. And it has been reported that there are no significant difference in diagnostic accuracy between the three of them. The only radio tracer that you have to avoid is the MDP, that it is not suitable for evaluating the ATTR cardiac amyloidosis because it has been reported that it has less sensitivity when detecting the cardiac amyloidosis. In order to know what to expect from the bone scan, it is very important to know the pathophysiology of the uptake of the bone radio tracer. Well, the thing is that the exact mechanism of uptake in cardiac amyloidosis is unknown. Well, it has been hypothesized that it has something with the calcium metabolism, and the ATTR amyloid plaque contains a high concentration of microcalcifications. It's also been reported that there is much greater uptake in ATTR amyloidosis than in AL amyloidosis. There is a higher concentration of microcalcifications in the biopsy. And also the DPD uptake is massive in myocardium of patients with TTR-related amyloidosis, almost absent in myocardium of AL patients. But this is not, in our experience, I have seen only one case of AL amyloidosis, so in a score 3 Perugini, and most of them are a score 1 or 0. And the thing is that both groups, AL patients and ATTR patients, can present soft tissue uptake. It's also been reported that the DPD may bind to specific fragments of the mutated or wild-type TTR protein, and it binds to the fibril and not to the calcium or the necrotic tissue or the microinfarction. So it is not really known, and this is very important because the different treatments goes or attack different pathways of the disease. And if we don't really know the exact mechanism, maybe we are not really allowed to compare studies between before and after treatments. So there are a lot of investigations running now, trying to see if there is any difference with the treatments. So we are just waiting for the results. So just in order to not collapse the nuclear medicine department with plenty of bone scan scintigraphies, there are indications for the bone scan. Well, most patients with older than 60 years with ventricular hypertrophy with preserved ejection fraction and increased wall thickness without apparent cause. Also, elderly patients with bilateral carpal tunnel syndrome, idiopathic neuropathy, and heart failure with echo or MRI showing signs of infiltration. Patients with known or suspected familiar amyloidosis, and patients with echo or MRI suggestive of cardiac amyloidosis. All these indications are summarized in the European European Society of Cardiology working group. Probably Dr. Fernando told you all about all these indications. So the image acquisition. There is a difference between the DPD and PYP. With DPD, we perform the whole body images, and also we do as the PYP the planar images. And I think that it is very important to add the SPECT, and if you have the CT, the SPECT CT, not in all cases, but in most of them. And also depends on the ability of the radiologist or the nuclear medicine physician. So, in the image analysis, what do we want to see? So we want to see if there is any cardiac uptake of the radio tracer. In the anterior images, in the planar images, the left ventricle, what we are going to see is a U shape open to the right. This is the U shape. While in the oh, sorry. Okay, sorry, it's having some issues with the camera. So in the lateral projection, we see this donut-shaped image. Okay, sometimes we can also see the right ventricle uptake. It is mainly in the lateral anterior oblique, left anterior oblique projection, and you can see this curved line extending from the apex toward to the externum. The atrial cavities are less common to detect and are identified as crescent shapes. You can see here the right atria and the left atria. In SPECT-CT, the activity is contained within the myocardium of the cardiac chambers, allowing for easy discrimination between the myocardial activity and the vascular pool. And what you have to see is a diffuse uptake that around inside all the myocardium. Maybe sometimes you can see some different focal uptakes, but with higher activity. But you have to see this diffuse uptake that affect the whole myocardium. SPECT-CT. Do we have to perform the SPECT-CT? Yes, no. In my experience, well, in our experience, in our department, there is no need to do the SPECT-CT for all patients. In a in a score 0 or in a very positive study, score 3, it is not going to add a lot of information. But with this score 1 and 2, I think it's mandatory to do the SPECT-CT. Why? Because the SPECT-CT enables accurate anatomical localization and quantitation by attenuation and correction. Also, it is helpful to determine whether the cardiac uptake is localized in myocardium. Enables accurate discrimination of myocardial uptake from the cardiac blood pool. And there is a more accurate quantitation at the standardized uptake value. Measurement is possible in SPECT-CT due to the attenuation correction. And also the SPECT-CT is very effective for evaluating extracardiac soft tissue uptake. Later in the speech, I'm going to show you some clinical cases that the SPECT-CT were crucial to give a perfect or a right report in the end. So we do the bone scan, but we have to make a scale of the uptake. Okay, so the most used visual scale is the Perugini score. It has 4 scores, 4 grades of uptake. We have the score 0, that there is no detectable cardiac uptake. The score 1, is low cardiac uptake, is less than the adjacent bone uptake. We have the score 2, is the mild cardiac uptake. is similar or a bit higher than the bone uptake. And finally, the score 3, that is a very strong cardiac uptake, and most of the times with absent bone uptake. Here are the 4 examples of the 4 different scores. Here we have the score 0, the whole body image. There is no uptake in the cardiac region. We can check the spexity, as you can see here. There is no uptake in the myocardium. Here we have the score 1. You can see this very, very low uptake here in the cardiac region. And in the spexity, we can see this donut shape, diffuse uptake of the myocardium. And you can compare very, very easily with the bone uptake, because there is no interference of other planes, tissues, and you can separately perfectly the bone activity from the cardiac activity. Here we have the score 2 uptake. You can see here that the uptake is similar or a bit higher than the uptake in the ribs. Here you can see the donut shape in the SPECT images, and this is the score 3. With the score 3, you almost see perfectly that it affects the myocardium, that the activity is not inside the ventricle, okay? And in the spexity, you can see clearly the activity inside the myocardium and not inside the cavity. But in DPD studies, we can check for extra cardiac uptake, and sometimes it helps you to give a higher score, and also it is very helpful for the prognosis of the patient. Right ventricle uptake and soft tissue uptake, both are very important for prognosis. So as you can see here, there is a slight activity here in the cardiac region. It's higher because there is absent bone uptake. There is a lot of soft tissue uptake. And when there is a lot of soft tissue, you can see here the sign of the empty bladder. Empty bladder, no. Empty liver, sorry. The empty liver, not bladder. Here we have the pathological uptake in the muscles of the gluteal region. Is the score 3 Perugini score. Here we have the activity in the cardiac region, in the left ventricle, right ventricle. Almost here could be the atria. The abdominal wall, it is very common to see this uptake in soft tissue. And also we have the cardiac pathological uptake. Here we can see also the gluteal muscles. Lung uptake, pathological lung uptake. Liver pathological uptake. More muscular pathological uptake and lung. It could be thoracic muscles or intrapulmonary uptake. With the spexity, you can really see if the activity is inside the lungs or or are the muscles. And this is a curious case that the activity here is pathological activity inside the tongue. Okay, but also pulmonary activity, the cardiac pathological activity, abdominal wall, and absent bone uptake. It's a super score 3 bone scan. So, but we are not perfect. We have some false negatives and we have false positives. False negatives, well, mutated TTR forms may have lower ability for bone tracers like the bone met or the FELU. Also, the early stage of the disease, if the level of deposits below the detection threshold, and also if there is a presence of old infarct, because the scar tissue does not perfuse. The bone scan with the tracers, they are going to uptake are going to the different tissues through the perfusion. If there is no perfusion, the radio tracer is not going to bind. False positives, recent infractions, the hydroxychloroquine toxicity, the chemotherapy toxicity, pericarditis, the vascular pool, metastases and fractures, and the mitral or aortic calcification. Most of the false positives can be excluded with the SPECT-CT and with a very good clinical history and a very good check of the clinical history. So in order to give a useful report for the cardiologist, we have to make an easy report, okay? And in our experience, we follow these steps, and we are going to make this step 1, that is the visual interpretation. If myocardial activity exceeds on the SPECT or in the planar images, we are going to proceed to step 2. But if not, the visual scale is 0 and the study is negative. So we are going to write bone scan negative for cardiac ATTR amyloidosis. Step 2, we have activity. So we are going to perform the visual semi-quantification on planar and SPECT images. If it is difficult to determine that the bone scan is positive or negative, we can go to the step 3 and use other quantification methods like the heart contralateral ratio. But most of the times, and I think I have never used these quantification methods before. It is not recommended in guidelines to use it in clinical practice. And I think that with the SPECT-CT, you don't really need these extra quantification methods, because you can clearly separate the activity from the myocardium, from the soft tissues and the bone uptake, and you can really say if there is or no uptake inside the myocardium. So we have the score 0, negative study. Grades score 2 and 3 are consistent with ATTR cardiac amyloidosis, is going to be the positive study. And score 1 is the equivocal. So negative, equivocal, or positive study. Just be simple in your reports. This is what I think that most of cardiologists expect from us, from the nuclear medicine physician. Just tell me what to do. Next step. So summarizing, if the cardiac amyloidosis is suspected, we just run the test, the serum test. If it is positive for light chain proteins, it is an AL amyloidosis. If it is negative, we can perform the bone scan before going to the biopsy or okay. With the score 2-3, we can say that it is positive for ATTR cardiac amyloidosis. We can run the genetical test. And if it is scored 0 or 1, is up to the clinic. So depending if you are really thinking that this patient has cardiac amyloidosis, you just go for the biopsy. If you don't really think that he's going to have this cardiac amyloidosis, you can just follow up the patients and avoid him any invasive test. So I'm going to show you some clinical case of our department, just to see some very interesting case. This is the case 1. This is the typical negative study. Score 0. We don't have any uptake on the planar images of the whole body. There are no soft tissue pathological or extracardiac uptake. Here in the planar images, there is no activity, any activity inside the cardiac region. So there is no need to do an expect or an expectancy in these cases. Just say it's negative study and it's okay. But what happens when we have activity? I'm going to show you two very similar cases. This is the case 2. Here, well, this patient has a lot of bone uptake because of trauma diseases. Has hip joint replacement, some vertebral fractures here, but here in the planar images, you see there is this slice of activity, very, very low activity. Okay, we go to the planar images. And yeah, we still see this very, very low activity. And in the oblique projection, we see this kind of donut shape, very, very, very low uptake, but could be a score 1. Okay, we perform in this patient the SPECT-CT. I think this kind of patient is the best patient to do the SPECT-CT. And what do we see here in the SPECT? That the uptake is well, there is uptake in the cardiac region. Okay, is lower than the bone activity, but it is very focal. There is no diffuse uptake. So we have transformed score 1 an inequivocal study to a score 0, a negative study. So this patient is negative. Then case 3, this patient is very similar. We have this very low activity in the cardiac region. You can see here in the posterior images, there is activity here, here, and here. Planar images, activity here. And we can see this donut, the donut shape of the activity of the left ventricle. Okay, let's check the SPECT-CT. And as you can see here, maybe there are some focal uptakes higher than the bone uptake, but you can see that there is a diffuse uptake of all the myocardium. So this is a positive study, and it was a score, a real score 1. Well, you can say, but this activity is higher than this one. But checking the other uptake or different ribs, it was very similar. It was less than the rib uptake, so it was a score 1. But you can see the diffuse, the difference between the focal uptake, diffuse uptake. Just remember that. Case 4. This is the easy one. Very, very, very positive bone scan. There is almost absent bone uptake. We have this very high cardiac uptake inside the myocardium, left ventricle, right ventricle, and also here we can see the right atria. Also, there is some abdominal wall uptake. In the planar images, we can see the other cavities, cardiac cavities, the typical donut shape of the left ventricle. And in the SPECT-CT, you can see perfectly that it really, for you cardiologists, it is very similar to when you do the perfusion images in cardiac diseases with the MIB technetium, and it's very similar. You see the uptake in all the myocardium, left ventricle and right ventricle. It's very similar, the image, as the perfusion images of the MIB technetium. And the final boss. This was a recent study. Here we have plenty of things. we have extracardiac uptake. Could be the liver or could be the lungs. And also in the planar images, there is activity in the cardiac region. Could be this could be the liver, but this I don't know if this is inside the lungs or it's just a muscular uptake. So we perform the SPECT-CT. What we saw that first of all the activity in the thorax was inside this atelectasia because of a pneumonia. This patient had a pneumonia. And what we are seeing is the higher perfusion of the region. The higher perfusion in a soft tissue, the higher uptake of the bone scan radio tracer that we are going to see. And if we check the cardiac activity, it's a very high activity inside the cardiac region, but you can see that all the activity is inside the cavities. You almost see the negative of the myocardium here. There is no uptake inside the myocardium. Everything is inside. It is the blood pool. Also, you can see the vessels with activity inside. Okay. So these patients went from a score 2 to a score 0 negative study, from positive to negative study. And that's all. I hope you enjoy the presentation, and yes, I'm ready for all your questions.
Thank you very much for fantastic presentation, Professor Cardona. And now we have some time for discussion. And let me start from the first question that I am interested in. So, hereditary transthyretin amyloidosis. You can stop sharing, by the way. You can stop sharing.
Okay.
So, we identified our patient, we find transthyretin cardiomyopathy. Then, in the relatives, for example, we see the presence of some mutation in the family. So, could you please advise? In this situation, is scintigraphy recommended for the relatives, for the family members? For example, ultrasound was done and hypertrophy is about 12 millimeters. I'm speaking about the thickening of the myocardial wall. So what do you think? So we don't see any red flags in the relatives, in the family. So what do you do in such case?
Well, I think this is more a question for the cardiologist, but we have started an investigation in familiars with cardiac amyloidosis, and I think that it is a non-invasive test. And well, it has been reported that there is a very low percentage of patients, of young patients, because the percentage of positive cardiac activity is higher in patients older than 70 years. It is very rare to see this uptake in people younger than 50s or 40s. But I think that in this kind of patients, it is a non-invasive test. I think it's not really going to harm the patients. And maybe a first test, I think that it could add some positive things when following up these kind of patients. And in our experience, I think almost we have performed 10 10 to 20 patients, young patients, with a relative positive for cardiac amyloidosis, and all of them were negative. It was a negative study, score 0 Perugini. But maybe I think it can help you. It can help you just to check these rare conditions and to help you in the follow-up of these patients, because probably when they get old are going to develop the disease, and before they start to have these clinical symptoms, I think it's very important to rule out the disease.
Thank you very much. I have another question to you. So please advise, do you think it's reasonable to carry out scintigraphy in dynamics if patient getting tophamidis, if patient is on active treatment? So during follow-up, if yes, how frequently?
At the moment, there is no evidence if there is no evidence if we have to perform these follow-ups with the bone scan. As I told you before, we don't really know the exact mechanism of the bone uptake. So the different treatments attack different pathways of the metabolism in cardiac amyloidosis. So we don't really know what we are seeing, and it is difficult to check these uptake changes in the bone scan. There are several studies. We are involved in 2 or 3 studies that are trying to see if there is a difference between the bone scan radio tracers after and before and after the treatment. As a spoiler, I can tell you that we are seeing that there is a lower uptake in most of the patients in a particular treatment, but I am not allowed to talk about that more. But more studies and more papers. We need much more studies to see if there is really a relation in the better performance of the patient and the uptake of the bone scan scintigraphy.
Thank you very much. And now I'm happy to give the floor to our colleague, Professor Alexey Anshels. Maybe you have more questions because you are also a specialist in nuclear medicine. Well, we all know that cardiologists better speak to cardiologists, but radiologists with radiologists, they always find the common language. So I think we can transfer our discussion after my presentation. Yes, I have some questions, but I'm sure that it would be more logical to ask all the questions right after my presentation. And I know that we have some questions in the chat, one from Chelyabinsk, and he's asking what is the interval that you do whole body scan after you inject radiopharmaceuticals, so especially cases with poor accumulation in bone system, because it used to be 1 hour, now it's 3 hours, but laboratories, they cannot wait 3 hours sometimes, and we need to understand what should be the timing, what's the interval.
Okay, makes sense to me.
Will you answer it now?
Okay, sorry. I thought that you expect me to speak later. Doctor speaks. So when to do the images depends on the radio tracer. With the DPD, it is okay to do it from 2 hours to 3 hours. The thing with the blood pool activity, I think that you can, if you do the spexity, there is no problem with the blood pool. So you can do it. You can do the scan 1 hour, 2 hours, 3 hours. If you see that the activity is inside, or you see the activity inside or outside. So if you do the spexity, it doesn't really care. But there is something with this timing. We have to remember that it is a bone radio tracer, and it is very important to wait the optimal uptake of the radio tracer inside the bone, because in the visual score, we need a perfect contrast between the soft tissue and the bone uptake, because we are going to say that a scan is positive or negative, interpreting this difference of uptake. So for DPD, the best timing for to have a very good contrast between the soft tissue and the bone uptake is from 2 hours to 3 hours. So in my opinion, I think that 2 hours it is okay, because you are comparing with a very good uptake, a bone uptake. But sometimes not all patients are similar. Maybe they have some renal diseases, some renal insufficiency, and this bone uptake it is not going to be as good at 2 hours than 4 hours. And in this kind of patients, maybe we have to wait a bit more to have a scan with a higher quality and a much better contrast. So I have had this issue with all the investigation that we are involved, because most of them, they ask for at least 3 hours to wait, and we have to. We also do this our clinical practice, and I have to make try to fit all the patients and the hours with the clinical practice, and sometimes these 3 hours are not very good. So, but I think that this is because of the investigators. But in clinical practice, if you use the DPD, I think there is no problem if you do the images 2 hours, because the bone uptake is going to be optimal. So, in my opinion, if you are not investigating and they don't ask you to do the 3 hour delay images, with the 2 hour delay images is okay. And with the PYP, if you perform the spexity with 1 hour, it is okay. But it depends depends on the investigators. But in clinical practice, in my opinion, 2 hours, 2 hours for DPD, 1 hour for PYP, it's okay.
Thank you very much. Thank you for the response. We have another question, and let me ask first part of it. The question is, and I will try to answer this question after you myself. Did you see combined forms, AL and ATTR amyloidosis? I am commenting on that because the largest register we had in this disease, this is British-Swedish registry with several thousand patients. So it seems that, yes, there are such combined forms, and why they suspected it? Because in several patients, they saw accumulation of radiopharmaceutical in the heart, and also they had light change. But the further analysis of the register showed that in each of these cases, one method failed. So in big register appears to be that no true combined cases. And another question about the quality assurance of radiopharmaceutical after you make it. We know that's a tricky question because we know that pyrophosphate, PYP, if there is some wrong procedure, could give us colloid, and this colloid will be accumulating in the liver. And you told us that DPD could give us the phenomenon of empty liver. So with pyrophosphate, we get the opposite, so-called full liver. And I think the author of this question would be interested to know how you do DPD and how you do the quality assurance of DPD. And comment on the combined ATTR and AL amyloidosis. Please, Jorge.
Okay, well, the second question about the liver uptake. We also have seen most of the times I don't really give a strong value to the liver uptake. Yes, to the empty liver, but not to the liver uptake, because also DPD, we have seen that it has a higher prevalence of non-pathological liver uptake. So we just assume that there is no pathological uptake in the liver. Yes, with the empty liver, but with this the image that I showed you before, they performed the biopsy and the amyloidosis was confirmed in the liver. So that's why I put it on the screen. And with the first question, the mixed amyloidosis. It's a tricky question. It's a very hard question to answer. Well, I think that it is very important to rule out I mean, I have to think it. We have to know that the bone scan results are not good alone for diagnosing the ATTR cardiac amyloidosis. It is very important to exclude the AL amyloidosis with a serum test, and sometimes in some departments they also they are working with the beta amyloid PET radio tracers. But at the moment we are not working here at the hospital with the beta amyloid for cardiac amyloidosis. But yes, sometimes happen that I think we have 1 or 2 cases here at the hospital that it was both diseases. I think that they were together, but it is impossible impossible to discriminate if the 2 diseases collide with the bone scan. I think that you have to perform a much more diagnostic test, MRI, echo, biopsy, also the PET-CT images. I think that the bone scan alone, it is not the perfect technique to exclude the cardiac amyloidosis. When the AL amyloidosis has been excluded, you can trust in bone scan results, but after excluding the EL. Because also we have seen these patients with AL amyloidosis with the score 1, score 2, only 1 case with the score 3 amyloidosis. But yes, I think that don't use the bone scan alone.
Thank you very much. Well, dear colleagues, and now we move on, and the next presentation would be made by Professor and Doctor of Medical Science, Alexey Anshels. The floor is yours. You're welcome. Good afternoon, distinguished colleagues, dear cardiologists, dear radiologists. Well, in fact, my presentation is called Popularization of Nuclear Diagnosis among Cardiologists. That's why I will say a few words to the main methods of nuclear cardiology that we would be happy if cardiologists are using them in their clinical practice. And first and foremost, slides are a little bit delayed, and mainly this is perfusion scintigraphy of myocardium. So this is the only method of direct ischemia visualization with identification of the surface. So this method of diagnosis could influence the treatment of patients and prognosis of the patients. We have positron emission tomography, PET. It extends the option of non-invasive diagnosis in cardiology. PET with FDG already in the guidelines on many non-coronarogenic pathologies, non-inflammatory stations, and perfusion PET can assess the reserve. And if we compare perfusion and metabolic PET, PET, then this is a golden standard to assess the viability of myocardium. We also perform some other very traditional studies of the target organs in cardiological diseases. Mainly, we look at lungs and kidneys. Speaking about cardiac amyloidosis, well, this is a relatively new format, actually the big branch of nuclear cardiology. And if the main method of visualization, diagnosis, and typing of cardiac amyloidosis was endocardial biopsy with mass spectrometry, so now, according to the majority of the guidelines, in order to have primary diagnosis of amyloidosis, most frequently echo is used as main method and MRI as a second-line method. And there are some patterns. And there are several patterns. We speak about the typical changes in cardiac amyloidosis. We would be happy to use expert echocardiography, and we identified typical morphological features. Then the diagnosis of cardiac amyloidosis is very convincing. MRI is quite expensive, and also it requires contrast. That's why for us it's more clarifying method, which is add-on to echocardiography if echocardiography is not convincing enough. And then the most interesting differential diagnosis of IL and transthyretin amyloidosis. And it's carried out with laboratory data, results of immunofixation, serum in the urine, and also phosphate complexes. And this is pyrophosphate, also several diphosphonates. So in Russia, we have all of them available, but what we use most frequently is PYP, which is pyrophosphate. Well, that's a very convenient situation because these are the same radiopharmaceuticals which are also used for the skeletal bone scintigraphy, and this is most important screening method in oncology. That's why all the labs which are doing bone skeletal scintigraphy could be really continue doing scintigraphy with PYP specifically for myocardium. And currently, this method is actively implemented all over the world, and it is very smoothly and seamlessly came into our practice, especially keeping in mind support of the specialized cardiological and radiological communities. Speaking about Russia, the most important tasks for us to popularize this method. So this is not just for cardiologists, but also for radiologists, because we are expert center on amyloidosis. We're excellent center on amyloidosis. With the support of Pfizer, we carry out a lot of activities with radiologists, and we promote the idea that this method, bone scintigraphy, is very simple, but it's quite demanding to the type of images and interpretation of the results. So in our laboratory, in our work, in the training of the specialists, we stick to protocol and we insist on that. It should be very stringent. First of all, it should be proper activity, at least 20 millicurie. Then records in 3 hours, after the injection of radiopharmaceutical. That's why we're asking Jorge about it, because for us, it's 3-hour protocol for PYP. And then good quality of images with parameters mentioned here on the slide. We also insist on using hybrid methods and using CT match, because we need anatomical guidance. And another important moment, that we are using the best reconstruction algorithm which are available in the manufacturers of our equipment. Only when we stick to these requirements, we get good diagnostic results and reduce the error rate. And in fact, there are many errors, mainly false positive. So here is an example of axial slice, and using color scale and initial algorithm of reconstruction, it's absolutely non-informative, and only when we process it with a specialized algorithm, we can see that the accumulation of radiopharmaceutical is in blood pool. So we see signal from ventricles, from atria. So this is pure grade 0 by Perugini. Score 0. So, and it should be the same precise approach. And we prepared this reference slide to train radiologists. So we give our own images, reference images for each grade, and we ask them to be guided by them. So we identify accumulation of radiopharmaceutical exclusively in the myocardium, not in the blood pool. And for that, we need tomography of proper quality and match with CT. We provide our results, and we have about 115 patients where we carried out the studies with a final diagnosis, and we performed myocardial scintigraphy. In fact, not all of them had hypertrophy phenotype, although such patients also come to scintigraphy. So that's the diagnosis our patients had, depending on the presence and the type of hypertrophy phenotype. Grade 0. Grade 0, it's excluded transthyretin amyloidosis in all the cases, but in 17 patients, they had AL. So the other most frequent diagnoses here are other cardiomyopathies, restrictive cardiomyopathy, the other etiology, mainly sarcoidosis or accumulation diseases, or hypertrophic cardiomyopathy, or most frequently just hypertonic hypertensive heart. Grade 3 and 2 actually didn't cause any challenges in interpretation. So it used to be always transthyretin amyloidosis, except 2 patients with AL amyloidosis. And later on, I will speak more about it. And 10 times in our practice, we mentioned grade 1, but we try to avoid such conclusions, because in fact, that's equivocal. Neither nor, either positive or negative, and score 1 or grade 1 are most difficult for the analysis, and grade 1 requires best quality of image recording. So in order to understand what's that, so all cases of grade 1 in our cases met AL amyloidosis, all of them. And as I said before, the biggest challenge for us is to get grade 3 with AL amyloidosis. And one of such cases is here. This is patient age 61. And here the accumulation of radiopharmaceutical, both in the right and in the left ventricle, is so intensive. So we can just process it even for Polar Maps software. So this is clear grade 3. And definitely this result forces us to describe that this is typical for transthyretin amyloidosis, and probably because of that, patient had hematological tests only 1.5 months later after scintigraphy. They found out monoclonal gammopathy, and 2 weeks later, the patient died. That was AL amyloidosis, and we believe it's a very important methodological problem in order to understand why it happens, why still rarely, but we see such results. So why the radiopharmaceutical is accumulated in AL amyloidosis? And trying to answer this question, we have to pay attention to the mechanism of accumulation of these phosphate-labeled complexes in human organism. Jorge said, yes, we don't know everything, but for the last few years, we got quite a lot of microscopic studies that show us some enlightenment. Let me share this information. So these are bone products, and accumulation of these products in the bones, it's clear. So phosphate, labeled phosphates, like normal phosphates, so they're binding with calcium. And finally, we get calcium phosphate, which is deposited as hydroxyapatite in the matrix. When we do scintigraphy, we can see what? Skeleton, we see osteoblastic metastasis and inflammation and aseptic necrosis, which also happens due to the release of calcium from the cells, most frequently in the joints and in the dental area. But if we speak about myocardium, so here, phosphate complexes have some affinity to the free calcium or active calcium complexes. That's why these radiopharmaceuticals are used in the situations when we need to visualize pathological process, whether the calcium metabolism is deteriorated or if there is degeneration of cell necrosis with mitochondria death and release of free calcium. In the real practice, when we see it in acute MI, acute myocardial infarction. So we see fibrils destroyed, we see minor calcificates, and pyrophosphate is bound to that. And finally, we get this patchy, very bright accumulation of drug in myocardium as a marker of acute injury of cardiomyocytes. And in this case, it's acute MI. So in such case, what's the mechanism of accumulation of pyrophosphate in cardiac amyloidosis? We used to believe that the drug locally bound in amyloid fibrils, but now we have clear confirmation on these micro pictures. You can appreciate that these calcifications, they albeit not as such a degree, so you can see it in one shot, but most frequently they're not coinciding in localization. But if you do von Koss sustaining, which emphasizes the grade of mineralization of the tissue, that means we try to find out non-dissolvable phosphates. So mainly we see these particles in transthyretin amyloidosis, but not in AL amyloidosis. And this is exactly the part of my presentation I will be happy to discuss with Jorge. We have a hypothesis. Pyrophosphate is not a marker of amyloidosis. It's a marker of the necrosis burden. And at the end of my presentation, I will have one slide with this question in English. But let's go back to scintigraphy. So our experience of doing this method allows to predict that this method could be used not only for differential diagnosis of different types of amyloidosis, but also for the neighboring clinical situations. First, if we take patient with grade 0, which is negative result, then that would be a very diverse group of the patients. In majority of the cases, in such patients, amyloidosis is actually excluded. But in the same group, we could see the relatives with familial form of transthyretin amyloidosis and approved mutations, so relatives of the proband. And if this relative has grade 0 right now, so that means this relative of the proband has no even the earliest features of cardiac involvement, and we need to follow. And as soon as this relative has new grade, and we see it long before echocardiography, so since then we can already discuss the prescription of treatment. And the same refers to the patients with suspected wild-type form of transthyretin amyloidosis. In every 5th patient, 1 out of 5 with grade 0, we finally have AL amyloidosis. And although we were not connected to these patients, although they were treated in hematology in different sites, but still we can suspect that grade 0 in AL amyloidosis could mean non-complicated type of disease when oncohematological treatment could be beneficial. Now grade 1. So these are difficult to interpret patients. So in our group, it was always AL, but this is our experience, but it was different AL. So they were patients normally with more negative prognosis if it's grade 1, but not grade 0. But this is a small group of the patients, so possibly we could have here patients with initial transthyretin as well. And now grade 2 and grade 3. If hematology is negative, then we can confirm ATTR amyloidosis, and at the same time, with the prescription of pathogenetical treatment, we can ask a question. Using scintigraphy, can we follow these patients in dynamics? Can we follow them up? using scans from time to time. So we believe that the absence of worsening for 12 months is already positive result. So no worsening. So this is 12 months of tafamidis treatment. So that's ratio of heart versus contralateral is not changing. So that's a very good situation. Heart contralateral ratio. And our two cases, grade 3 with AL. Oh my God. In both cases, it was feature of terminal type of disease with a very, very fast fatal outcome. So this is our area of IL amyloidosis, and this is extremely evil. And I think here cardiologists would appreciate any instrumental help. So that is why I wanted to discuss new options and new indications for myocardial scintigraphy, which is not just for differential diagnosis between two types of amyloidosis, but also in the context of universal assessment of myocardial injury severity, keeping in mind how pyrophosphate is accumulated in myocardium. So in any indication of myocardial injury, but definitely it's very disputable. But dynamic follow-up using bone scintigraphy, it's a reality. So we have our small experience, limited experience, and it actually coincides with the larger trials. And this is one of French studies. It showed that tafamidis 12 months treatment reduces the percentage of HMDP accumulation in myocardium. It's a French publication. But we spoke about the mechanism of accumulation, and let me say again, this is not the reduction of amyloid burden. No, this is a slowing down of cardiomyocyte destruction, cardiomyocytes that are next to amyloid fibrils. So wrapping up my presentation, I would like to emphasize that in case of management of such patients, we should have multi-instrumental approach, and it is possible only in excellent centers. For the first time, this approach was done in Mayo Clinic. So currently we have about 20 sites like this, and one of them in Chazov Center in Moscow. And we have a big team of multidisciplinary specialists, several labs and several departments, several wards. So we are working on this issue together. With that, I thank you very much for your attention. So these are my questions to Jorge. I will keep them on the screen, and if we have a discussion, we can open these questions later on. Thank you very much. Thank you, Alexei. Thank you very much. So I don't know what would be the best way to do. Maybe we first ask questions to you, or maybe Jorge would would answer your questions. Oh, yes, let's do it. Not to forget. So the questions that you wanted to ask. So please start your discussion, because you are two specialists of nuclear medicine.
Well, actually, can I see again the questions, because you have changed the TV, and I don't really see the questions now. I'm watching myself. Perfect. Thank you very much. Well, first of all, congratulations to Dr. Anshales for the presentation. It has been very good presentation, and with some very good topics. So actually, well, I don't have here we don't have much experience with PYP. So I think I'm not really allowed to talk about the PYP questions, but I think that I concur with Dr. Anshales that we are not seeing the amyloid burden. We are seeing the myocardial damage. We agree in that, and I think it's I think the uptake in the bone scan uptake is more the higher perfusion of the inflammation, because also we see this higher perfusion in patients with pericarditis or with toxicity of the chemotherapy, and it is because of the, I think, because this inflammation, this higher perfusion. So we agree in that we are not marking the burden. We have for that we have the beta amyloid PET radio tracers, and yes. So can I take again the questions, please? Okay. Why is the percentage of my noise less? Well, I don't really have this. Well, I don't really have more answer. But maybe if Dr. Anshelles start to talk, it can be more dynamic and my neurons activate, because I'm having just a bit of lost in translation here. So.
Jorge, thank you very much for your comment. Yes, my question is massive, but in fact, let me simplify all that. We believe that all phosphate complexes behave similarly, no matter what is PYP or something else. So we believe, based on our experience, that scintigraphy with phosphate complexes pyrophosphate or DPD can be used in AL amyloidosis to assess the stages. But although it was clear, even without us, because AL dying patients, AL amyloidosis dying patients is not the one who should come to us. But we had at least 2 patients like this, and there is another one with yet unknown diagnosis. So we can even say that there were even 3. So in my understanding, both DPD and pyrophosphate are markers of necrosis. But in case of IL amyloidosis, it's fulminant, it's very fast, it's very aggressive, and it leads patients to the terminal outcome. So probably we can park this question and we can move to the questions we see in the chat. So there is another question. So when do we have to repeat scintigraphy to the relatives of the patients that currently have grade 0? It's the same situation. So we are just at the forward of this event. We are just starting getting the patients' offsprings of the probands. So we just started dealing with them. So we don't know. For example, the family member is, let's say, 40 years old, no manifestation, but his father has a fulminant picture. We had already 3 cases like this, and we checked them once, and we said, yet grade 0, do nothing. But when to repeat next scan? In 3 years? In 5 years? We don't know. Maybe Professor Terещенко knows. No, looking at him, he doesn't. Definitely, probably, we can suspect that we can see it earlier than echocardiography. But if we just wait for thickening of the myocardial wall, we don't want. It's not ethical. But on the other hand, myocardial scintigraphy is quite cheap. It's quite cheap and simple. And if cardiologists desire, we can always redo it in 3 years, for example. Jorge, maybe you have your position, or what do you do? So what should be interval in follow-up?
Yeah, actually, we are now in an investigation when to perform this follow-up in familiars of familiar cardiac amyloidosis. This happened with other diseases in nuclear medicine with the PET-CT for some kind of tumors. When to perform the follow-up? 1 year, 6 months, 3 months. In order to see the evolution of the uptake, I want to, maybe I'm going to share you a clinical case that we have. Okay, just to think about this this time schedule for follow-up. So let me check the bottom here and here. Okay. So, do you see the picture?
Yes, positive. Please speak up.
So I'm going to tell you about this particular case. This is a male patient, and we perform different bone scans. He is a prostate cancer patient. So as you can see, we start to not me, but sometimes happens that when the nuclear medicine physician it is not an expert on cardiac amyloidosis or cardiac nuclear medicine, he just goes to the bone pathology, just check for metastasis. And this is what happened. This is a prostate cancer patient, and the nuclear medicine physician didn't see the uptake in the cardiac region, unless in this study in 2013. I think that Professor De was the physician that checked the bone scan instead the other colleague, and he noticed that, and he started to check and perform a retrospective study. And from 2011, as you can see here, it started the uptake, and every year it changed from score 1, the next year changed to score 2, 3, next year score 3, and here only past 3 years, and in 3 years we have changed from score 1 to score 3. So when to perform the follow-up? In this case, this patient, with 1 year evolution, we can really see the difference in the probably not the amyloid burden, but probably the myocardial damage. So for me, maybe this if it is a grade 0, maybe 2-3 years could be okay. Could be okay. A good timing for follow-up. But 1 year in patients with grade 0 that are very young, maybe, I don't know, 40 years, 50 years, the high percentage of uptake in cardiac amyloidosis is in patients older than 60, 70. So maybe if there is no uptake in the first study, maybe 2-3 years, and also 5 years could be a good timing. But if you see any kind of activity, this is score 1 or very, very, very low activity, maybe 1 year is a good timing to follow up.
Thank you very much. Thank you very much, Jorge. Well, as we are a little bit behind the schedule, then we are moving to the third presentation, because Alexei already made a bridge, and here are my slides. So this is a very short presentation on how multidisciplinary team should work and how it works in our Amyloidosis Excellence Center. We know very well that right now Multiple centers are established around the world, and there are more than 20 high expert excellence centers. And the same happened in Russia. We have a National Cardiology Center named after Chazov, and we established the only in Russia excellence center in trans-thyretin amyloidosis. Well, I'm not diving deep into well-known facts that amyloidosis is one of the main problems, that this is life-threatening situation. Yes, in fact, we spoke a lot about it and we know a lot about it. But today we are saying that today amyloidosis is seen not so rarely as we think before. So yes, we mentioned IL amyloidosis today. And you will see how many patients refer to us under the mask of transthyretin cardiomyopathy, and then we start diagnosing them and we see IL amyloidosis. And definitely we immediately refer them to our colleagues hematologists to be treated urgently for chemotherapy. You can appreciate here that IL amyloidosis and transthyretin cardiomyopathy, transthyretin amyloidosis, so totally it's about 95% of all cases of amyloidosis. And this is the data on incidence, how frequently we see transthyretin cardiomyopathy in different categories of the patients. It could be a hypertrophy cardiomyopathy, left ventricular hypertrophy in arterial hypertension, and here you see 13% of cases. Then aortic stenosis, 16% of the cases where we make the diagnosis of transthyretin cardiomyopathy later on. Then heart failure patients, heart failure with preserved ejection fraction, 17%. So this is not our data, this is international data, and actually we started studying patients with aortic stenosis that come to TAVI, transaortic valve replacement, but we don't see such levels like in publications. We examined already about 2,000 patients, 2,000 with TAVI, and we don't get 16%. No. In our situation, no. We may speak only about 2-3% from the TAVI pool. Maybe TAVI population is different in our country. It's difficult to say, but it's not coinciding with international data. But we fully understand that in order to deal with amyloidosis, in order to diagnose, in order to become the excellence center, definitely we need collaboration between multiple specialists. It cannot be just one cardiologist who is making the diagnosis of transthyretin cardiomyopathy. Definitely, this is the diagnosis of exclusion, and first you need to exclude AL and other cases. We have to use with radiology, radioisotope methods. We should involve neurologists to work with these patients to make the diagnosis correctly. So it's always a multidisciplinary approach, and only this way we can successfully achieve some results. And we need to establish such highly specialized excellence center all around country, because country is very large, from Kaliningrad to Kurilsky Island, more than 6,000 kilometers, and definitely it's difficult to refer patients from Vladivostok to Moscow with a distance of 6,000 kilometers to be diagnosed. So this is how we published our data, our excellence center for 2 years, 24 months of experience. Well, figures are different, but let me share. Here you can appreciate how fast we increase the referral rate. So at first, mainly they were patients that came on their own, and here we appreciate that later on, let's say 2 years later, we see the uplift of referral. Referral rate is increasing because in our center, we are not simply making the diagnosis. We are educational and methodological center. We also train, we educate healthcare professionals, we increase their awareness, their knowledge about this pathology. Unfortunately, in our medical textbooks, if we open amyloidosis chapter, almost nothing is about diagnosing them. So, and patients, they graduate without knowledge of this pathology. And by now, already more than 318 patients, 180 that came to us, and from them we make diagnosis of amyloid cardiomyopathy to 120 patients, 120 out 380. Definitely there were some other diagnoses where we did not confirm amyloid cardiomyopathy. There were some other diagnoses made, but let me draw your attention to the gender and age characteristics, which are shown here. So in this pie chart, we can appreciate that 34% are females and 65% are females, which is true. And the average age for us is 60 to 69 years old. So that's the range. So that's the majority of the patients that came to us and followed by us. And here is distribution between IL and transthyretin amyloidosis. So we see here pretty high percentage, specifically for patients with IL amyloidosis, 55%, and this is higher than transthyretin cardiomyopathy. But again, patients with IL amyloidosis, here we also diagnose problems with cardiovascular system, which are cardiopathies, and this is very important, not only for transthyretin amyloidosis, where we see cardiopathology, but also in case of IL amyloidosis. Today, a lot was said about the diagnosis, so let me skip it, but we clearly can appreciate that the basis for everything is definitely instrumental methods, which are shown here. This is bone scintigraphy, this is echocardiography, and MRI, etc., and other methods. Well, symptoms and manifestations that we see. So this is involvement of cardiovascular system in 79% of the cases. Involvement of peripheral nervous system. So we have patients with amyloid cardiomyopathy, but at the same time, that there is nervous system involvement. So we can appreciate that 17% of the cases had renal involvement. So we created and designed clinical guidelines on the chronic heart failure that later on were approved by the Ministry of Health last year, 2024. And actually for the first time, in these guidelines on the heart failure, we very clearly prescribed the algorithm of diagnosis making of amyloid cardiomyopathy and the options of treatment which are available, what should be recommended to chronic heart failure patients that developed as a result of amyloid cardiomyopathy. Well, definitely we exclude traditional treatments which are typical for heart failure. These are beta adrenal blockers, and in these guidelines, we also strongly recommended to prescribe tafamidis. So currently, we are trying to implement these methods of treatment very actively. Definitely, there are challenges, and that's very clear, but actually, this is medical consilium, and the expert center conclusion allow to extend tafamidis use and prescription rate for patients with transthyretin cardiomyopathy. So once again, I would like to emphasize that my colleague said today, that we follow patients that are getting tafamidis, and the dynamic of follow-up is important. So we want to use scintigraphy for that. It's not the dynamic, it's a process of non-progression. So it's important to understand that amyloid accumulation is ceased, is stopped. And this is very important, and this is how we can see the positive effect of this treatment. Well, dear colleagues, we had such active and interesting discussion at the very beginning. Our time was very limited, and I think we depleted our time. So with that, I would like to thank our distinguished colleagues, specialists of nuclear medicine, and express huge gratitude to you because without you, we would never be able to move on, to move forward with the understanding of this pathology, with the correctness of the diagnosis and correct interpretation. And I do hope that there are great perspectives of further promotion and popularization of the method of diagnosis like bone scintigraphy, and most probably we'll speak more about the role and place of PET in the diagnosis, and maybe at your level we would be easily differentiating AL from transthyretin without complicated methods. As you said, it's cheap and effective, and we will be able to avoid biopsies. So with that, I thank my colleagues, experts, and to our audience. If you have any other questions which are left, open questions, please refer them to us. We will try to answer them next time, and hopefully this is not our last meeting. Thank you very much. Have a good evening, and goodbye. Well, Professor Cardona, thank you very much. It looks like we finished.
Perfect. Thank you very much.
Thank you for your connection. Thank you for your time and for very interesting presentation. Thank you. Thank you very much. Have a good evening. Goodbye.
You too. Bye-bye.